Hi, everyone. My name is Dr. Navarrete Reyes. I'm a geriatrician, and I work in Mexico City at the Instituto Nacional de Ciencias Médicas en Nutrición Salvador Subirán at the Oncogeriatric Clinic. First of all, I would like to say that I have no special disclosures to make. Here is an outline of my talk. We'll be discussing a little bit about the definition of cancer survivorship. We'll talk about also the epidemiology of cancer survivorship, cancer care trajectories, survivor needs, health-related outcomes, and survivors' needs. Sorry, I said that already. Health-related outcomes in older cancer survivors, and about the possible role of comprehensive geriatric assessment in these specific patients. The concept of cancer survivorship was first described in the New England Journal of Medicine in the mid-1980s by Dr. Fitzhugh Mullan. He evoked people living with and beyond cancer. From the beginning, three phases were described: an acute phase defined as the diagnosis and treatment of cancer, an extended phase that defined the period following treatment, and a permanent phase that really roughly is equivalent to cure. On time, the National Coalition for Cancer Survivorship defined a cancer survivor as someone from the moment of the diagnosis of cancer through the end of life. And nowadays, these definitions has been expanded to include family members, friends, and caregivers of individuals with cancer. And it is a very inclusive definition. However, although most patients after diagnosis and after treatment of cancer do identify themselves as cancer survivors, not every cancer survivor feels comfortable with this term for a range of reasons. Regarding epidemiology, the number of cancer survivors is growing exponentially. In 2016, only in the USA, there were 15.5 million cancer survivors. And this figure is expected to increase and reach 20 million and over by 2026. Older adults aged 65 and older represent over, or more or less, 64% of cancer survivors, and they will make about 70% by 2040. So this is a very important population to know about. Cancer is largely recognized nowadays as a chronic condition, and survivors continue to experience a myriad of symptoms as well as late effects well beyond the treatment, their oncological treatment. Cancer survivors can experience different clinical trajectories. They may live cancer-free for the remainder of their lives, or they may live many years without cancer to present a late recurrence. They may also live cancer-free for the rest of their lives, but they may be suffering the complications of oncological treatments. On the other hand, there are cancer survivors that live with intermittent periods of active disease requiring treatment, and others that live with cancer continuously without a disease period. These clinical trajectories will determine the corresponding cancer care. For example, in patients with an active oncological diagnosis, the treatment is usually carried out by an oncological treatment and an oncological team and a palliative care team, while those survivors without an active cancer diagnosis are usually treated by their primary care physician. For many cancer survivors, these care transitions are not as smooth as they should be. They may feel abandoned by their oncologist, or may fear that the primary care physician is not able to follow up on their oncological diagnosis. Therefore, our attention has shifted to how the needs of these persons, of these cancer survivors, can be met. The needs of cancer survivors have been described for a long time now. Survivorship entails issues related to healthcare, to cancer follow-up, treatment follow-up, issues related to late effects of treatment, second cancers, and of course, quality of life. So there is a myriad of health conditions that belong to these different clusters of survivors' needs. As we can see in this slide, we have different clusters of symptoms in the physical well-being and symptoms. We include things such as functional ability, sleep or rest, pain, appetite, and overall physical health. In other clusters, such as the psychological one, we include symptoms such as pain or distress, fear of recurrence, overall perception of quality of life. We also consider a social well-being cluster that includes the assessment of things such as appearance, affection, sexual function, finances, isolation. And finally, we also consider a spiritual well-being sphere that includes things such as religiosity, transcendence, uncertainty, and hopefulness. At heart, all this summarize that life after cancer is rarely experienced in a similar way to life before cancer for these patients. Now, despite the demographic shift we talked about a few slides before, survivorship programs have primarily focused on the late effects of cancer diagnosis at younger ages, and the impact of cancer in its treatment on older adults' health and functional ability and on the underlying aging process is not well understood. To understand such an impact is critical, since older adults have their own specific set of needs, apart from those that cancer survivors have. In the next few slides, I will try to show you how older cancer survivors have different prognosis compared with younger cancer survivors. For example, in this study that was carried out in the population of the Baltimore longitudinal study of aging, and that included 1,728 men and women aged 22 to 100. The authors showed that cancer survivors, especially older, demonstrated greater odds of accelerated functional decline as per grip strength and gait speed, suggesting that cancer and or its treatment may alter clinical trajectories of cancer survivors. If you pay attention to the figures, you can see that in color green and orange, or that the younger patients are represented in colors green and orange, and the older patients are represented by blue and by purple. The patients with a history of cancer that are over 65 years old are on color purple, and you can see this group of people is the one with the highest probability of weak grip strength and the highest probability of a slow gait speed. They behave much worse than their younger counterparts, even though some of them have a history of cancer. This other study was also carried out in the VLSA population. In this case, we have 1,600 participants, more or less, and 20% of them reported a history of cancer. In this case, the authors showed that among cancer survivors 65 and older, endurance walk deteriorated significantly over time, and this deterioration was greater among those who had a history of cancer, meaning that, and you can see it here, that older adults with a history of cancer slowed down about 42 seconds in the endurance test over follow-up, more than younger adults without a history of cancer. And finally, we can see this other study that was carried out in the atherosclerosis risk in communities study cohort, where patients were followed up after they were diagnosed with different types of cancer over 15 years. And what they looked on was functional status. And these authors showed that functional status scores where 100 is better, is the best functional status, and 0 is no functional status left. They showed that functional status scores compared to the cancer-free group, except for prostate cancer, declined over the first year of diagnosis, and that they continue to decline beyond 1 year after lung and colorectal cancer diagnosis. Functional status was lower in all cancer groups compared with non-cancer groups, except for prostate cancer, and predictors of decreased functional status were age, low education, comorbidities, obesity, and smoking, and also lack of insurance. So in this figure, you can see the functional status through time according to the type of cancer. And you can see that patients diagnosed with lung cancer are the ones that behave the worst in terms of functional status through time. So the potential synergy of aging and cancer may place the older adult at risk of adverse health-related outcomes, like you just saw. And the studies I've just shown you reinforce the need to develop intervention studies to prevent or mitigate cancer and cancer treatment associated functional decline in this population. Now, we all know that the comprehensive geriatric assessment, which is a multidisciplinary diagnostic and therapeutic process, can improve the detection and documentation of problems in this population. And it is also related to improved health-related outcomes in a specific clinical settings. So we wonder what the possible role of the comprehensive geriatric assessment may be in these older cancer survivors. Recently, several randomized trials have been published, and they showed that implementing CGA-based recommendations and interventions improved outcomes, different outcomes, including severe chemotherapy toxicity and quality of life in patients in the acute phase of survivorship. Nevertheless, these interventions, these CGA-based recommendations and the co-management by a geriatrician has not been systematically studied in the extended and permanent phases of cancer survivorship. With this in mind, we have prepared symposium to explore and share information and experiences regarding older cancer survivors and their care. Over the next 40 minutes, we'll hear 3 different presentations regarding care planning, needs assessment, and quality of life in older cancer survivors, and I hope you enjoy. Thank you. Next, we'll hear a talk about needs assessment of older cancer survivors in Mexico by Dr. Juan Pablo Negrete Najar.
Hello, my name is Juan Pablo Negrete, and I will talk to you about needs assessment of older cancer survivors in Mexico and a tiny experience that we had on the subject. As you know, Latin America and Mexico also are undergoing a rapid population aging as a result of epidemiological transition. We are starting to see more chronic diseases rather than communicable diseases. And this includes cancer. So the projections for Mexico are that by 2030, we will have 75% increase in the cases of cancer detected. And most of them will be in the older adults. This has to deal not only with the epidemiological transition, but also with the better treatments and care that have been discovered and designed for cancer. And this, of course, causes a better survival. So we are bound to see more and more cancer survivors that are over 60 years old. We know that cancer survivors have particular needs in healthcare, and those that are older adults have even more particular and specific cares. So we think that older cancer survivors have multiple unmet needs in addition to their problems that we know because of age, such as comorbidity and loss of functionality. So what do the survivors need or want? That is a question that has to be answered population specifically. What I try to say is that different populations tend to report different needs. So we talk about this in the terms of unmet needs. What are the things that the survivor feels that need to be fulfilled in order for them to have a better welfare? So unmet needs provide an opportunity to assess the gap between what the patient has as a concern and the level of assistance they require and the one that we are providing. The interesting thing about this is that unmet needs are influenced not only by the cancer the patient had and the treatment, but also by characteristics of their functionality, their family network, and also their social determinants of health. So knowing about all these spheres of the patient is necessary to provide the best care that we have. I will present to you just a few examples about needs assessments on cancer survivors. This first one is a Livestrong poll that was developed in 2005 that had over 1,000 participants. This included all ages, and it is really interesting because people that were participating in this poll refer that they had secondary health problems, other things that bothered them or impacted their life that were not the cancer and the cancer treatment. So around half of them had other health problems. And the ones that were mainly identified were chronic pain and sexual problems, and also infertility. It is really interesting to see that the emotional support sphere was mentioned by a lot of the participants. 70% of them were depression, and it is alarming that 78% of them did not seek any kind of help. And particularly talking about unmet needs, in this poll, they found that around half of the participants reported that their medical needs have not been met, even when they were going to regular consultations. And we also have the non-medical needs, with also around half of the population reported that emotional and practical day-to-day things and that changed as a consequence of being a cancer survivor were more difficult than the medical ones. In this same poll, they found that financial problems were really important as people gain debt because of the treatment costs, and also work problems. A lot of people, just because they had cancer, they were out of their job, and some of them, because of they had symptoms and late and long-term effects of the treatment, lost their job or position. And some of them were trapped because of health insurance expenses. So as you can see, not only health problems are mentioned. Then we have the experience in Mexico, which is a small one. As far as I know, there have been just a few efforts to make an inquiry about what are the needs in cancer survivors. This first one here was made by the National Institute of Cancer in Mexico City. It is a self-report registry of cancer survivors. So you enter the web page and you enter your data. This registry started in 2014. Since the last report they gave, they had over 3,000 participants. Most of them were long-term survivors. And it is interesting to see that almost all the sample referred that they had some kind of long-term side effect, such as fatigue, bone pain, or neuropathy. And also, as you can see, the mental health sphere is really affected. 95% of the sample referred that they had either anxiety or depression. And you can also see that they had sexual health issues and also problems with re-entering work life. They also reported that 50% of them had some sort of relapse of the cancer that they had. So this registry is still going on, and as far as I know, until the day of recording this talk, there hasn't been any other report about it. We have also this experience, which was an abstract from ASCO 2016 in a survivorship symposium. They had 1,200 participants from different parts of Mexico. And these patients fill a 32-item questionnaire that had questions about their life, their symptoms, and what were the long-term and side effects that they had because of cancer treatment. As you can see, only 15% of them were older adults, as reported by the authors, but the range of ages have people up to 91 years. So this is interesting for geriatricians and people that take care of older adults. So as you can see here, they also reported fatigue in a little bit over of the half of the sample, and also bone pain and skin changes. And it is interesting to see once again that the mental health sphere is mentioned as something really important. 60% had fear of recurrence and anxiety related to it. 44% had just anxiety by any cause, and depression 55%. And finally, I would like to tell you about this example made by Dr. Perez Cepeda and Dr. Navarrete Reyes, which is one of the Mexican efforts to see how cancer survivors do, but particularly older adults. So what they tried to do is they compared 288 survivors to over 7,000 patients, older adults, that never had a diagnosis of cancer. And they classified them by frailty using a frailty index, and they found that those who were cancer survivors had a higher risk of incident frailty. And also, they found that there was an inverse association between remote cancer and the worsening score in the frailty index. So it seems like as time passes by, since the time of diagnosis and treatment, patients tend to be less frail. So in the hospital where I work at, the National Institute of Medical Sciences and Nutrition, or Instituto Nacional de Ciencias Médicas, we have a comprehensive cancer clinic in the elderly, CICAM by the initials in Spanish. And this clinic was started in 2015 by Dr. Patricia Navarrete. And the aim of the clinic in that time was to perform comprehensive geriatric assessments in older adults that were programmed to receive some kind of cancer treatment. So since then, the clinic has been growing. And in 2019, just a few months before the pandemic started, we started a survivorship consultation. What we wanted to do with this survivorship clinic was to follow patients that were 70 years and older that had a history of prostate, breast, colon cancer, and also non-Hodgkin lymphoma. And we survivorship as those patients that have completed 1 year of surveillance after completing their primary treatment. And because of the pandemic and the transformation of our hospital into a COVID center, we could only see a few patients. So since July 2019 to February, we had 26 patients. And I'm going to show you the little data that we found about them. So we had 18 women and 8 men. The mean age was 78 years old. We had 7 breast cancers, 18 colorectal, and 1 melanoma of the scalp. We used the St. Louis frailty tool to classify them. So we had 9 non-frail, 15 pre-frail, and 2 frail patients. 15 patients were classified as having polypharmacy, and we had 4 that had nutrition issues. 14 were classified as probable sarcopenia using the SARS-F tool. And which is really interesting is that 21 of the 26 patients had some kind of deficits in their instrumental activities of daily living. And we also found 5 abnormal mini-COGs, 7 patients with constipation that had no treatment, 9 with urinary incontinence. Only 1, even though they were all cancer patients at some time, had advanced directives. And only 3 had their vaccination schemes completed. And you can also see in this screen that we found some other troubles, like they didn't have their screenings, the regular screenings completed, though they were cured or at least in control of their cancer. And we also found 9 with mood disorders between anxiety and depression. So with this little data that we found, we then decided to do another needs assessment, but trying to incorporate determinants of health, social determinants of health, and also other characteristics of the patient and their cancer that could impact the needs they have. So far what we have done is a validation of the SF-SUNS, which is a standardized tool to inquiry the patients about their unmet needs. We'll just show you briefly that we have already translated it, and right now we are piloting it. And we also did a translation and validation, transcultural validation of the NCCN survivorship proposed list of symptoms. So the next step we're going to do is to use this in our clinic to find the unmet needs of our patients. And this is really important to us because we believe that unmet needs are modified by a lot of things, and that also modifies the health expenditure, and this will help you develop a better clinic and a better follow-up plans in outpatient clinics and work with the patients in order to empower them and provide a better care for them. I thank you for your attention, and those are my contact data in case you have any questions. Thank you.
Thank you, Dr. Negrete Najar, for your great talk. Next, we'll hear talk about survival in older cancer patients and its consequences regarding specifically quality of life by Dr. Garcia Martinez.
Hello, good evening, Argentinian time. I'm Juan Garcia. I'm a geriatrician in Madrid, Spain. I currently work with palliative care patients and geriatric patients, and I'm going to speak a bit about survival in older cancer patients and its consequences. And I'm going to focus a bit in quality of life aspects of cancer patients. So first of all, we have to have two themes in common, really concepts which are really important. First of all is quality of life, and the other one is long-term survivorship. So when we speak about quality of life, there is no really one definition, one consensus about it, but we have many different definitions. The one I like is the one of the WHO, which speaks about individuals' perception of the position in life in the context of his culture, system of values, where they live, what are their goals, expectations, standards, and concerns. Okay, so that's what we are going to speak about. On the other side, when we speak about survivorship, we speak about people who has been diagnosed with cancer and have survived since the time of diagnosis. But long-term survivorship implies that they have lived 5 or more years. So if we look at the cancercontrol.cancer.government website, we have more than 15 million cancer survivors, which are considered long-term survivors, which of them, 18% of those survivors have lived 20 years or more since diagnosis. This includes, of course, elderly patients, but also there is a big amount of people who has been diagnosed with cancer in the childhood, and they have survived because they are cancer-free and they have no problem with it. So first of all, the concepts, which are quality of life and and long-term survivorship. And other thing we have to have really clear is that how we measure quality of life. There have been created lots of instruments for it. In this systematic review, which I liked, they speak about quality of life instruments in long-term breast cancer survivors. So when we measure quality of life, according to Farrell, he defined in 1996, 4 different dimensions about quality of life. One is physical well-being, psychological, social, and spiritual well-being. So in this systematic review, they analyzed different instruments, different studies, and they found that 12 different instruments evaluated the domains in long-term survivors from cancer, from breast cancer patients. So 3 studies evaluated all 4 domains. So 3 instruments evaluated all 4 domains, and the other 9 evaluated different domains, but not all of them. So these 3 studies or these 3 instruments are quite useful to evaluate quality of life in long-term breast cancer survivors. But we have to take account that these studies they are not really from the late years. There are articles published in the 1990s, 1995, or 2000. So the problem with it is that if we measure quality of life, we can have this false sense of security that we are measuring it, but it's also true that population changes, priorities changes, and its quality of life changes also. So we have to take that in account, not only because it's important to understand what quality of life means to every person, but also because sometimes it may be not actualized it. And also that we use this kind of instruments to measure quality of life in a kind of population, but it has been tested in other kind of population, for example, breast cancer survivors. Other way of exploring quality of life, it's not to explore different domains in a concrete cancer, but to explore concrete domains in a population. So, for example, we can explore pain, which is a concrete domain, in long-term survivors of childhood cancer, which can be a lot of different kind of cancers. So, in this study, they analyzed the repercussion of pain in quality of life in patients with childhood cancer. And it's really interesting because pain has really a lot of different dimensions. So they analyzed disease-related pain, treatment-related pain, procedural pain, and yes, of course, the diagnosis of cancer, and how these different aspects caused poorly managed pain, and it had some consequences. Now, here in this case, they speak about chronic pain in survivorship, but also lifestyle changes, emotional distress. So it's also useful to analyze not a domain as a whole, physical domain, but for example, pain, anxiety, depression, insomnia. There are symptoms, concrete symptoms, that give us a lot of useful information. Here, they analyze, for example, that fatigue in pain, in cancer, and sex, in this case women, were associated with more pain. So sometimes we can ask the patient about his fatigue, and it may be possible that he says that he has no pain, but he has fatigue. And in the future, it implies that he is going to have pain. So we have to treat everything. But the idea of this speech is that there are coming new times for many reasons, but we have to have new focuses to do our studies. It's not only a straightforward way. We can take a round on the left or the right. We're going to end at the same place, which is helping patients and understanding the quality of life. But anyhow, you have to know that there is not only one way to find a solution. So in this study, for example, I liked it because it's a bit old, but they studied not the quality of life loss because of cancer, but the perceived positive impact of cancer among long-term survivors of childhood cancer. So it's quite interesting because they focus on how the family helped each other, how the physicians or the nurses were there to help them, to give information. So it's another way of focusing on the study of the quality of life, and I think that's a more positive. So that's good also. Or, for example, not only focusing or studying the loss of quality of life, but also what can we do for preventing it. In this case, they try to prove that yoga helped to improve chemotherapy-induced peripheral neuropathy. Or these other two studies, which were really interesting. So here, the focus is different. They propose different approaches to the intervention to the treatment of a cancer. There are more studies about radiotherapy, for example, but here they spoke about laparoscopic colectomy versus open colectomy, or parotid sparing and quality of life. So after intensity modulated radiation therapy. So here they choose to see, they try to see if approaching differently to one kind of cancer, you obtain the same results with better quality of life, which is great. Because, for example, in the parotid sparing and quality of life, the first article there, the one above, they proved that the results were the same, but people had much less dry mouth. Maybe if we propose treatments, we can dialogue with patients about what we want or what they want. And maybe even if there is a bit of less survival, depending on the case, of course, maybe they choose that option because they will live with better quality of life. So maybe the quality of life is starting to have a balance in the treatment options. And the last article I wanted to bring you is the vitality of mortality. So being throughout death and long-term cancer survivorship. So there is people who has been next to death experience. There is people who have had next to death experiences related to cancer, and they are long-term survivors. So how does the life of those people change? I mean, philosophically speaking. So I think this article is great because, of course, it's published in the Journal of Medicine and Philosophy. It couldn't be published anywhere, but it's very interesting how they twist the way of watching the different aspects of quality of life and the different aspects of perceiving life itself. And I couldn't resist the urge to end my study without mentioning two of the greatest Argentinians I know, so to say, but they were wrong. The Les Luthiers here, they were wrong because they say happy those who don't expect anything because they won't be disappointed, and they weren't right because we have to try something. We have to expect things from life because otherwise there won't be any change. So I think it's really comfortable what they say, but they weren't right. And the last thing I wanted to say, just to give the thought of the twist in studying about the quality of life. So it's a terrible task to swim in a circle which center is everywhere and which circumference it's nowhere. So it's really a mess, and Cortázar said like that. So the thing is, maybe we shouldn't swim in that pool. We should just get out of the pool, dry ourselves, and try to think something different, getting out of the circle, because otherwise we will do the same thing that always has been done. So thank you very much.
Thank you, Dr. Martinez, for your enriching talk. Next, we'll have time for questions by the audience.
Hi, everyone. Thank you for joining us in this symposium about older cancer survivors. Thank you, Juan, and thank you, Juan, from Spain. I have a couple of questions. I would like to ask Juan Pablo Negrete, since he is my co-worker. We work in the same institute, so I know he has been interviewing patients about survivorship needs, and I know he has some data already, so I would like to know if you can share a little something about that with us.
We have really few data. We have interviewed around 15 patients, and the only thing that comes to my mind that's different from the data we talk about in the videos, is that people are actually surprised of being asked their needs, especially when you ask needs that are not medical. So that is something interesting. And also the focus of these patients have also been the fear of recurrence, and also about their comorbidities, and they have this kind of feeling that once they transition their care from the oncologist to another medical consultation, that something may be lost, and that is something that is also described in the literature. So far we don't have that much data because getting the interviews done has been difficult, but so far it seems some things are quite like the literature refer. And one other thing is that the patients that we've seen in the survivorship clinic tend to be really functional. I mean, most of the patients we've seen have good, they have their activities of daily living preserved, which is interesting, and especially compared to the literature.
You mentioned that they act surprised when you ask them about their needs. Since you guys trained in the USA at the Moffitt Center, do you find this interesting or different from the cancer survivors you used to see back in Florida?
Yes. The people in Florida, or at least in that hospital, tend to be more healthy and less frail than the patients we see here at the geriatric oncology clinics. Particularly for the survivors, I think they tend to be similar, but I think that's bias from our hospital. I think that the patients that we see in the survivorship clinic are the ones that have been living longer and don't have many comorbidities, because in the way our hospital is organized, the patient with comorbidities go to those services. For example, if they have Helicobacter pylori infection, they go to the gastroenterology department. If they have depression, they go to the psychiatric department, or they can go to the general geriatrics consultation. So I think that we still have to make more publicity about the survivorship clinic in order to have more patients that actually need the services. But I think that with time, it'll happen.
I don't really know. I haven't read about it, but do you know? Of course, go ahead, Dr. Garcia.
Speaking of what Dr. Negrete said, in our area in Spain, at least at the area of my hospital, we don't have that kind of problem because we have a social security. So most of the patients come to the same hospital. They go to the public services. But what we find at the oncogeriatrics clinics and long-term survivors is that they are not usually referred to the geriatrician, because although they could be referred because they are frail or they are elderly and they could benefit from a geriatric assessment, the oncologist or the urologist or the specialist that treats that kind of cancer, he doesn't know or he's not aware of the existence of the oncogeriatric consults, so they don't refer them to us. So it's we lost quite a bit of patients because of that. It's true that the patients in Florida, for example, are quite different, but it's not only the patient, but also the physician that cares about the patient, for the patient.
So how do we deal with that? Are there any strategies useful or even available to make other physicians aware of older cancer survivors' needs, aware of the existence of oncogeriatric clinics that can take care of them?
I think that is something, I mean, we have to gather first evidence. I mean, that's what Dr. Negrete also said. So that we don't have it's not that easily to assess the quality of life of elderly patients that are long-term survivors is also complicated. There is not much evidence about that because usually elderly patients are happy enough to survive cancer, so they don't pursue or they don't try to get better health outcomes and better quality of life and better geriatric assessment. So we have to gather first evidence, educate our patients and our professionals or coworkers to show them what we do and how can we benefit them. And I think with that, with good evidence and congresses like this one, and we are going to achieve at the end. I mean, I think we are much better than we were 20 years ago, for example, or 10 years ago. So I think we have made great improvements, although there is much more, there is room for improvement still.
Dr. Negrete?
I think that two practical points to increase the interest in geriatric consultation. One is to find a geriatric champion in the other services. If you find somebody that cares or has asked you about what do you do as a geriatrician, or if you find somebody that in their medical notes writes down instrumental activities of daily living or something like that, that is a person that could help you to be the bridge between both services. And the other one is one that it's an advice that was given to me by Dr. Exterman in Florida, is that you should, when you are giving talks to your fellows or your residents, maybe invite somebody that you believe that doesn't know anything about geriatrics to give a talk about geriatrics. For example, an oncologist that you know that is that never treats older people or that treats them as young patients, maybe invite him to give a talk about toxicity or survivorship. And by making him give the talk, he might read some of the geriatrics literature and maybe gain some interest in it. So I think those are two practical points that you can try to do to increase the interest in geriatrics.
Interestingly enough, we have a question from Dr. Casale here in Mexico. Hi, Itamar. And he says, in order to initiate an oncogeriatrics clinic, what step do you consider most important to convince oncologists or hematologists about the importance of a geriatric assessment during the diagnostic and treatment of cancer in older adults? What would you say?
I think the first thing will be to have some data on the patients. So if in your hospital, you should check maybe the medical experience or the medical records in order to find how well or how bad older adults have been doing with chemo, for example, to see if they have toxicity or if they have to go to the urgency department. And also talking to the people that are involved in the care of those patients is very important. Maybe finding a middle point between what they do and what you are trying to do as a geriatrician, and explaining to them that you are not telling them what to do. You are just giving them some advice on the particular, the small things or the very fine things that you do as a geriatrician to help them care for their patients. And also that you will take some of the burden they have of taking care of patients, because instead of just them having to see a patient, maybe you can help them with the polypharmacy or the depression or the other health problems that a cancer patient might have.
Yeah, I would go for the same, but I would also say that we need to approach the oncological and hematological teams and to be able to have an effective way of communication. Sometimes the medical files are not enough. You have to go talk to them about the patient and get to know what they're thinking or planning on related to treatment and prognosis, so you can be useful to the patient. And so you have a good idea of what the oncologist or the hematologist is thinking. I don't know if you have an opinion about this, Dr. Garcia.
Yes, I mean, I think it's quite different, the situation, I suppose, in Mexico as in Spain. So I would add to what Dr. Negrete said, that if the hospital or the medical directors of the hospital think that that oncogeriatric consult is important, I would try also to let them help me, not to oblige the oncologist or the hematologist to accept me, not that, but I think that trying to, I mean, sometimes it's just like hitting against a wall that won't break. So I think sometimes the help of authorities or figures that are above you and above everybody is helpful, because at the end you can show them the benefits of geriatric assessment in oncogeriatric patients and in hematological cancer patients, elderly. But sometimes the help of yes, a medical director or someone like that can really help. Not to, I mean, it's complicated because the idea is that not anybody finds it as an obligation, but I don't know if it's, you have to make it soft. And at some point, I think it's also interesting to have data not only about toxicity and all the things that Juan Pablo said, but also about the population that is in your area, for example, and the prevalence of cancer, and how many of them are elderly people. I mean, those are data. No, at the end, you have I don't know, a number % of elderly patients who have cancer. If they are not well treated, it has some consequences. Sometimes is to show them the consequences of what they do and what they don't do, and what they could do if you were there. I don't know.
Lovingly.
What? No? What?
Lovingly.
Lovingly, of course. I mean, yes, lovingly, let's say so.
Okay, I have another question from Dr. Hernandez, and he's saying, what do you propose to improve recognition of these needs in BC oncological and in BC oncological and geriatrics clinics? Do we have a G8 for survivors?
I think the first thing would be to ask them. So there are several instruments that you can use. You can use the SF zones. If you have more time, you can use the expanded zones questionnaire. There is also an NCCN symptom list that you could apply to the patients. And I believe that the geriatric assessment, in any way that you do it, involves or asks about all the things that you should ask a cancer survivor. So just doing a geriatric assessment can help, but also doing one of these instruments. It all depends on how much time you have with each patient. So according to what is reported in the literature, you know, depression, anxiety, fear of recurrence would be very important things to ask. So if you want to just work on them, it's really important, and also fatigue. So as you know, these things are asked in a regular or in a typical geriatric assessment, or at least are screened. So that's a place to start. But if you have more time, you can use the ESF sums, for example, or you can use a treatment and survivorship plan, which is also one of the recommendations from ASCO and from NCCN when you care for survivors. So survivorship plans and treatment resumes just make you think about the kind of treatment the patient received, and what you are supposed to do in the next months. So those are already pre-specified plans that you can check and apply to the patient and modify according to the needs of your particular center.
I think we have time for another question. Dr. Garcia talked about quality of life assessment in this population, and I was wondering if there were specific tools or specific strategies designed to assess quality of life in this very specific population of older cancer survivors. I suppose, I know they have different needs, and I don't know if the concept of quality of life is encompassed well enough with the tools we already have available.
So the thing is that it's quite. I mean, I haven't really found any specific tool that you can use to assess that quality of life in elderly patients. I mean, you have the generic, the tools we usually use, but a tool to assess different areas of quality of life, or I mean, all the 4 different spheres of quality of life. I haven't really found that kind of scale. I mean, if you want to assess pain, you have a lot of scales that assess pain in long-term survivors. But if you look at that kind of studies, the problem we have that the population of the study is not usually elderly patients. I mean, you can use in elderly patients, but it's not. We would say it's not really validated in elderly patients. So that's the gap we find. Yes. That's the problem we find, and well, at least I find, and that's something I think we should change. I mean, we have seen. I also said that many quality of life scales that we use that are really. I mean, they are. We feel comfortable using them because they have great value. They are quite old. They are like 20 years old, 30 years old. So it may be time to change, or at least to adapt ourselves to our needs. One need is that younger people have different interests that they had 30 years ago, but it's also that elderly people is surviving much more than before. So we should maybe create a quality of life. I mean, in elderly long-term survival quality of life assessment. I mean, it may be time for that, I think, but no, I'm sorry, I don't have that answer.
Okay, thank you very much. Well, I think those were all the questions. It was wonderful to see you and to hear your talks. And thank you very much for joining us today.
Thank you for your time.